Chronic kidney disease, we check the eGFR in this. Modification of diet in the kidney disease, serum creatinine, age and ethnicity will affect the eGFR. Pregnancy, muscle mass, red meat within 12 hours of prior to the test. CKD and GFR milliliters per minute. I think this is per body surface area as well, 1.72 meter square. CKD stage 1 more than 90 with structural kidney damage. Stage 2 is 60 to 90 with structural kidney damage. 3A is 45 to 59, and here there is moderate decrease in the renal function. 3B 30 to 44 with moderate decrease in renal function. 4 15 to 29 severe decrease in renal function. End stage disease, that is CKD5, is less than 15 GFR. Established renal failure, requires dialysis or renal transplant. eGFR less than 25%, increase in the creatinine 30% is acceptable after administration of ACE inhibitors. Benign prostatic hyperplasia, the urine, you ask the patient to jot down urine frequency volume chart for 3 days. Management: A alpha 1 antagonist, tamsulosin and alfuzosin. There is decrease in the smooth muscle tone of prostate and bladder. First line, moderate to severe voiding symptoms. B 5 alpha reductase inhibitors, finasteride. Testosterone, DHT, BPH, decrease in the PSA by 50%. Enlarged prostate takes 6 months. Adverse effect: erectile dysfunction, decrease in the libido, ejaculation problem, gynecomastia. If storage and voiding symptoms persist, then antimuscarinic drug, tolterodine and darafenacin. Surgery is TURP. Alport's X-linked dominant, males are more severely affected. There is defect in gene coding for type 4. Collagen, abnormal GBM, anti-GBM antibody, good pasture syndrome. Clinical features: microscopic hematuria and polycythemia. Progressive renal failure, bilateral sensory neural hearing loss, lenticonus protrusion of retinitis pigmentosa and cataract. Then renal biopsy, in Alports you will see splitting of the lamina densa, and diagnosis is through molecular gene testing, renal biopsy, electron microscope, I told you, splitting of lamina densa of the GBM, that gives basket weave appearance. Okay, then these are separate entity. Anti-androgenic drugs are cyproterone acetate. It is co-prescribed when 3 days before starting gonadorelin due to risk of tumor flare, secondary to initial stimulation of luteinizing hormone released by pituitary gland. There will be increase in the testosterone level. Okay. Xanthogranulomatous pyelonephritis, chronic granulomatous disease, non-functioning kidney, chronic or subacute infection, protease mirabilis or white stones. Foamy macrophages are seen in this. Renal stones, what are the risk factor? First is dehydration, increase in calcium, increase in PTH and increased calcium urea. Cysteine urea, increased oxalate dyes. RTA, medullary sponge renal disease and polycystic renal disease. Beryllium or cadmium exposure, risk factor, urate stones. Gout, ileostomy, loss of bicarbon fluid, acidic urine and precipitate uric acid. Drugs: promote calcium stones, loop diuretics, steroids, acetazolamide and theophylline. This prevents calcium stones and increases distal calcium Rapidly progressive glomerulonephritis, there is rapid loss of renal function. epithelial crescents in majority of the glomeruli. The causes are good pasture syndrome, vaginous granulomatous, SLE, microscopic polyarthritis. Clinical feature में आप देखोगे nephritic syndrome होगा, hematuria with red cell casts, proteinuria, hypertension and oliguria. Then you will have thick capillary membrane in membranous glomerulonephritis. Clinical picture of nephrotic syndrome with proteinuria. Third most common cause of end-stage renal failure. On kidney biopsy under electron microscope, you will see bone basement membrane thickened with subepithelial electron dense deposits with spike and dome appearance. Causes are Apla syndrome, antiphospholipid A2 antibody, infections with hepatitis B, malaria, syphilis, malignancy like prostate cancer, lung cancer, lymphoma, leukemia, drugs like gold, penicillamine, NSAIDs, autoimmune diseases, SLE class 5, thyroiditis, rheumatoid disease. Management: ACE inhibitors, ARB, decrease in the proteinuria, improve prognosis. Immunosuppression in case of severe, corticosteroids with cyclophosphamide. Increase creatinine, progressive disease, symptomatic persistent nephrotic syndrome, tubulointerstitial focal disease is there. Alternating months you can give cyclophosphamide and corticosteroid for 6 months for membranous glomerulonephritis. Good prognostic features are female sex, young age, asymptomatic proteinuria.